Bismillahirrahmanirrahim. Good morning to everyone. My name is Dr. Ataullah Ahmad Zai. I am postgraduate resident of Ophthalmology Department, Nishter Medical University&Hospital, Multan. Today, my topic of presentation is glaucoma facts. At the end of the session, the audience will be able to define glaucoma, analyze its important feature and epidemiology, to classify glaucoma, and elaborate some important fundamentals. Number one, we will define glaucoma. What is glaucoma? It is a heterogeneous group of disease which is characterized by three things or by three parameters. Number one, optic nerve damage or optic neuropathy, raised intraocular pressure, which is normally, intraocular pressure is normally between 11 to 21 millimeter mercury, or visual field defects, characteristic visual field defects. Optic nerve damage. The optic nerve damage that we have in glaucoma, it's a characteristic. Actually, the glaucoma is the optic nerve disease in which there is raised cup disc ratio or raised CD ratio, and there will be subsequent loss of retinal nerve fiber layer. The retinal nerve fiber layer or ganglion cell death. As we can see in the image, normally we have this is the optic nerve head or optic disc. This is the cup, which is 0.3 cup disc ratio. There is progression due to progression of glaucoma. The cup disc ratio is increased to 0.6 to 0.95 cup disc ratio. This is the optic disc, this is the cup, the white area. In the center, this is the 0.6 cup disc ratio, and this is 0.9 cup disc ratio. It means that there is glaucoma is progressing, it's a progressive disease. There is also progressive glaucoma in optic nerve. Normal optic nerve, yes, moderate optic nerve, and advanced optic neuropathy we have, in which there is cup disc ratio is about 10 or 1. As we know that the glaucoma is a silent stealer of the vision, because the patient don't have any sign and symptoms. The patient don't have any symptoms like pain, especially in primary open angle glaucoma or chronic glaucoma. There will be no any signs. This is the picture of the normal optic nerve disc. Normal optic nerve disc, in which there is, this is the disc diameter, this is the cup diameter. Normally optic disc is orange and pink colors. The area between this cup that we can see, the area between the distance between the cup edge or the disc edge, it's called neuroretinal rim. In the glaucoma, this distance become decreased. Yes, we can see this distance become decreased. It means the cup disc ratio is decreased, the cup disc ratio is increased, or the neuroretinal rim become decreased. Agent rule. Agent rule means, in the agent rule we have normal, we have cup disc ratio. In the agent rule, the vertical diameter we are measuring in the cup disc ratio, not horizontally. We will measure the vertical diameter always. It's the rule. It means that in the agent rule, the inferior neuroretinal rim distance is more than superior, then nasal, then temporal. The large distance is inferior, the smallest distance is the temporal side. If we are measuring the optic disc or optic nerve head, we should take a slit lamp that will be narrow slit lamp. This is the slit lamp examination with 90°. Because if we use the diffuse light in the slit lamp examination, there will be more light, the patient will be discomfort very soon. So we will use a slit lamp beam that will be narrow. That is the rare signs that we can see in the glaucoma patients. Like in this patient, what is the findings? We have here hemorrhage, optic disc hemorrhage, raised cup disc ratio. It is also a rare presentation like nasalization of the optic nerve vessels by netting we can see, and also cup disc ratio is raised. So it means that the patient has some kind of glaucoma if there is any parameters of the glaucoma like visual field defect or raised intraocular pressure. At the first, we have said that in the glaucoma definition there are 3 parameters. Number 1, optic nerve damage or optic neuropathy. We have discussed about that. Number 2 is raised intraocular pressures. We have studied that intraocular pressure is in the general population it is 16 mm mercury, but at a standard deviation it can be 16 to 21 mm mercury. Upper range of normal IOP over 70 years is 23 mm mercury. In these individuals there will be no any glaucomatous damage to the eye. The patient IOP will be 23 mm mercury, but 4 to 7% over the age of 70 years IOP will be 21 mm mercury without any glaucomatous damage. It means it gives us the concept of ocular hypertension. If the person has ocular hypertension, his IOP will be raised, but if there is no any parameters of the glaucoma like optic nerve damage or visual field loss, we will don't mark the patient as a glaucoma patient. These 4 to 7% of people which has raised IOP more than 21 mm mercury, 1 in 10 will develop glaucoma over 10 years old, over 10 years, but the remaining will not develop any kind of glaucoma in their lifetime. So it means that glaucoma, we cannot mark a patient as a glaucoma just with 1 parameters like intraocular pressure we have mentioned. Intraocular pressure is one of the modifiable risk factors in glaucoma that we can modify. It means that if there is raised intraocular pressure, the patient will have very fast progression of glaucoma and very fast visual field loss or vision will be impaired very soon. The third parameter of the glaucoma is visual field loss, in which it is a characteristic visual field loss. Progressive visual field loss, it means the patient will lose its peripheral vision first, then he will paracentral, or at the end there will be central or tunnel visions. If the glaucoma is very severe and the damage is very severe, patient will have he will lose also the tunnel vision, and the patient will be NPL, no perception of light. The patient will blind. The damage that occur in glaucoma, that is irreversible. So we will be careful for this disease. At advanced stage, there will be tunnel vision. For example, if a person said to us that visual acuity, a person with moderate to advanced disease, his vision can be 6 by 6, if his CD ratio is 0.8, we can say yes, because the tunnel vision that we have in the glaucoma, his central vision is intact. Normally, if we measuring the visual acuity, that is central vision, he will have 6/6 vision, but he will have his peripheral visual field will be lost. Like we can say, in this is normal visual field. In the first diagram, first image, early glaucoma, visual field loss, advanced glaucoma, extreme glaucoma, in which the person is developed tunnel vision. This is another picture of perimetry. This is also the visual field loss. The patient is developing glaucoma, normal, early stage, middle stage, or advanced stage. The patient developed central visions. This is also, the patient has developed tunnel vision, but due to very severe damage to optic nerve, the patient is NPL. No perception of light, patient is completely blind. We said that the patient is developing tunnel vision. Why patient is developing tunnel vision? Because the patient who has glaucoma, in the retina or in the fundus, the fibers arising from macula follow straight course to the optic nerve head, forming papillomacular bundles. This is the papillomacular bundle that coming from the macula to the optic nerve. It is very straight to the optic nerve. But the other fibers which are coming from fibers which are coming from the temporal retina or from the nasal retina, it is not very straightful. But we can say that the bundles which are coming from the nasal retina, it's follow relative straight. But fibers from temporal retina follows an acute path. Yes, it's an acute path. It's relatively straight to the optic nerve. But this papillomacular bundle, which is present which is responsible for the central vision, the macula is responsible for central vision. It is more straight and near to the optic nerve head. If there is any severe glaucoma, these peripheral visual field will be lost, peripheral retinal nerve fiber layer will be lost, but patient will have papillomacular bundle which is more resistant to glaucomatous damage, and the central vision is belong to this. And the patient will, if there is severe glaucoma, the patient will also lose this papillomacular bundle and he will be blind completely. Retinal nerve fiber arrangement in the optic nerve. Fibers from peripheral retina, from the peripheral fundus, lie deep within retinal nerve fiber layer, but occupy most peripheral portion of the optic nerve. I will explain in the diagram the previous words. The fibers which are coming from the peripheral fundus that are more deep in the retina, but it follows when they are coming to the optic nerve, it is more superficial. Yes, number 5 is very deep, but when the passing from the optic nerve, it is more superficial. Like this, it is in the peripheral retina, it is more deep, but when coming, it is more superficial. The nerves which are near to the optic nerve head, it is more superficial, but when they are passing the optic nerve, it is more under center. It means the person who has glaucoma, the first he will lose these peripheral nerves, which are coming from the peripheral fundus. He will lose his peripheral visual field. Epidemiology, that is the second learning objective. If we have epidemiology, if we know about the epidemiology of a disease, so we will have a low threshold for diagnosis of that disease. How much the disease is prevalent in our society. 2 to 3% of people over 40 years has glaucoma, but 50% are undiagnosed. The glaucoma is the second leading cause of the blindness in the world. Number one blindness cause in the world is cataract, but the second irreversible blindness is due to glaucoma. Primary open angle glaucoma, which is the type of glaucoma, it is also called simple glaucoma. It is more prevalent in the white population, Latin, Hispanic, and black individuals. But primary angle closer glaucoma, that is more common in the Asian populations. But due to research or monitoring, if we do gonioscopy in the patient in the white population in the dark room, the prevalent in white, that is more than previously realized. General awareness about glaucoma is very less. The patient don't know about glaucoma. What is glaucoma? So in the society, we will give information to people that after age 40, if they have some problem with the eyes, they will do their complete eye examination, like he will check IOP, he will check examine the cup disc ratio, fundus examination, or also visual field or perimetry. In the Asian country, we have glaucoma week. In every week, we are celebrating that week with general awareness about glaucoma, with multiple seminars here. So for this reason, in the Western countries, we has the month of January, we are celebrating about glaucoma. Classification of glaucoma. There are two types. There are multiple types of classification of glaucoma, but the most important, the most simple classification is this type of that we will discuss now. Primary glaucoma, it is two types: open angle glaucoma or closed angle glaucoma. In the open angle glaucoma, the angle which is present between the iris and cornea, that is open. Normally, as we know that from the ciliary body, the aqueous which is produced, it comes across the pupil, and from the angle which is present in the anterior chamber, it drains to the trabecular meshwork through the canal of Schlemm and episcleral vein. But in the closed angle, this angle, in the closed angle glaucoma, the angle which is present between the iris and the cornea, it is closed. So for this reason, it's a primary glaucoma, its angle is closed. Yes, we can see it's iris, it's cornea. The angle which is present here, it is closed. The aqueous humor which is produced from here, it is not drained completely, so the patient has closed angle glaucoma. Another type is secondary glaucoma. Secondary glaucoma, it means it will be due to another disease. like due to any trauma, due to neovascular glaucoma, like in diabetes mellitus, the patient will have glaucoma. Steroid-induced glaucoma. A patient who is using for chronic steroid, like patient who has COPD, patient who has autoimmune disease, he is using for chronic for chronic times steroid, he will develop glaucoma. Another type is lens-induced glaucoma. In lens-induced glaucoma, sometimes the lens that we have in our eye, he will develop glaucoma. There are two types of lens-induced glaucoma. One is phecomorphic, another is phecolytic. In the phecomorphic glaucoma, the patient is developing, as we know from the name, pheco mean lens, morphic mean shape. Due to the lens shape, the patient will develop glaucoma. Due to imbibition of the water from the anterior chamber, the patient lens is swell in the angle which is present between the cornea and iris, that will close, and the patient will develop glaucoma. In phecolytic glaucoma, the patient will have glaucoma in which the lens protein will release in the AC, the patient will develop glaucoma. Another is glaucoma associated with inflammation. This type is associated with uveitis. In the diagram, we can see the medication like steroid can produce secondary glaucoma, eye disease like uveitis can produce glaucoma, trauma can produce secondary glaucoma, and diabetes like neovascular glaucoma. The patient which are presenting to us in emergency, that has the following features. Patient will have decreased vision, painful eye, the patient eye will be red, his pupil will be med-dilated, non-reactive to light, like we have in this, and corneal edema. In this picture, the patient has corneal edema, pupil is med-dilated, red, and decreased vision, and the patient will say to you, I have very severe pain, and nausea will also have the patient. We have classified glaucoma into primary glaucoma, secondary glaucoma, we have discussed about that. Now is congenital glaucoma. Congenital glaucoma, it is a rare type of disease in which in 10,000 one patient will have glaucoma. This type of disease it's more common in boys than girls. It is more bilateral but asymmetrical. Commonly, it means more bilateral means that the patient will have in both eye glaucoma, but asymmetrical mean that in one eye the patient will have IOP different from another eye. Genetic factor is always present in the congenital glaucoma because patient will have some mutation in the eye, and there will be maldevelopment of the eye, maldevelopment of the aqueous drainage systems. In primary closer glaucoma, it is not associated with any other anomaly of the patient. In the congenital glaucoma, there will be aqueous flow obstruction. In the aqueous flow obstruction, and there will be maldevelopment of the aqueous drainage system, and the patient will have glaucoma. As we can see in this patient, in this image, the patient has glaucoma. We will discuss later the signs and symptoms of glaucoma. Patient has glaucoma, but a patient with congenital glaucoma, he will have bull eye. like cow, very large eye. Why he is developing a ball-like eyes? Because he is, until 3 years of age, the collagen that is present in the eye, that is distensible. Until 3 years, if a patient is developing glaucoma, his eye will be enlarged. But after that, he will not develop ball-like shape. Because I think you have seen many patients after over 40 years of age, he will not have ball-like eye, because there will be no distensible, the eye is not distensible after that. Symptom of primary closer glaucoma. Normally the IOP will be not raised in the primary closer glaucoma. There are 3 common symptoms in the glaucoma that patient will present to us. The mother patient will say, one will be the tearing or epiphora, another will be blepharospasm or photophobia. But we will have one idea that in differential, we will say in the differential of the NLD blockage, which is the very common disease in our society, we will have differential about the primary closer glaucoma. We will rule out first primary closer glaucoma, because in the NLD blockage the patient will also has epiphora. Signs of primary closer glaucoma: the patient will has enlarged length of eyeball or ophthalmos. The patient will has cornea will be enlarged, that will be more than 12 millimeter. And like we previously mentioned, the patient is eye is enlarged due to until 3 years. After that, there will be no improvement of the or dilatation of the collagen that is existing in the eyeball. Classification of congenital glaucoma: there are 3 types of classification. Number 1, true congenital glaucoma. In this type, if there is IOP is raised in the intrauterine life, the patient we will call that true congenital glaucoma. This is 40%. Another is infantile glaucoma. In the infantile glaucoma, that is 55%. The patient will has manifestation prior to age 3. It's 55%. Another, the least common type, is the juvenile glaucoma, in which the IOP is raises between 3 years and between 3 and 16 years. Secondary infantile glaucoma, sometimes due to another disease, the patient will develop glaucoma, like in retinoblastoma, which is a tumor of the retina, malignant tumor. Another is uveitis. If the patient has uveitis, he will have glaucoma. In persistent fetal vasculature, the patient can develop secondary infantile glaucoma. Risk factors for glaucoma. As we can say that the glaucoma is the elder patient's disease, elder people disease. The age is one risk factor for that. If the patient has raised, if a person has his age is high, that's the one risk factor for glaucoma. Diabetes mellitus, family history, thin cornea, previous eye injury, myopia, hypertension, and systemic hypertension and vasospasm. It's a risk factor for the glaucoma. When we want to diagnose the glaucoma, we will measure the intraocular pressure with tonometry. We will evaluate the optic disc. We will have visual field testing with perimetry, and also optic disc OCT, optic nerve head, and also retinal nerve fiber layer. We will take that examination. Because if a person has glaucoma, if we perform OCT for the future evaluation of the disease or the following of the disease, that will be helpful. Treatment of glaucoma. As we know that the treatment of glaucoma is beyond the scope of this presentation, but as a general goal, we have two goals in the treatments: preserve visual field or prevention the loss of visual functions. These two goals are achieved by medication, laser, or conventional surgery. Thank you for your time and attention.